Welcome to this NISS ASA joint webinar today. Wendy Martinez, President of the ASA, will share our introductory slides. And I want to welcome, go full screen. Okay, I want to welcome everyone who's attending this webinar. It's a very relevant topic, COVID-19 and the role of modeling, and we have some wonderful presenters today. Next slide, Wendy. The opening remarks will be by Wendy Martinez, President of the ASA, and then we'll have 3 presentations followed by a Q&A discussion. Next slide, Wendy. NISS and myself, James Rosenberger, President of Director of NISS, and Glenn Johnson. And we have now over 400 attendees, view only, but there is a question and answer feature that you can ask questions during the webinar. Click at the bottom and type in your questions, and Wendy or I will present these to the speakers after their presentations. Next slide. Probably no one is new to Zoom at this point, but if you want to minimize the speakers on the screen, you can click at the top right. Upon completion of this session, you'll receive an invitation for an evaluation. On other devices, you might find these controls elsewhere. Tap on your screen and you will probably get instructions. Finally, we will have a video and copies of the slides on the NISS website after the, probably by tomorrow. Look there if you want more details on the slides. Wendy, let me turn it over to you and welcome the audience from the ASA.
All right, thanks. Can you hear me, Jim?
Very loud and clear, thank you.
All right, wait a second, I have to figure out what else was I going to share that I can't find now.
Oh, the ASA website you might put up.
Yeah, I don't know what happened to it. All right, let me just, oh, maybe I got to get out of this thing. So I guess you were wrong, Jim. Not everybody's, oh, here it is. Okay, that's because it was the wrong thing. You don't want to see my email here. All right, are you seeing the ASA?
Now we do, sure. Yep.
Yep.
All right. I want to go to the right. Yay. Okay.
There we go.
There we are. So thank you, Jim. This is the first, I think, NISS webinar on COVID-19. We're very proud to have ASA be a co-sponsor. And hopefully you're seeing the website here, amstat.org. As we know, data and the analysis of it's at the heart of dealing with COVID-19 issues. And I guess I should put my video on, but I forgot how to do that. Okay, here we go.
Bottom left.
Right. Sorry, hopefully that wasn't too scary. Anyway, because you know, we're going to talk about data analysis and modeling, it's essential that the American Statistical Association be a part of the conversation. So I'm really happy and honored that, that NISS invited us to be a part of this today. As you've seen, we have a very distinguished set of speakers for you today, so I'm sure we're going to learn a lot. I'll just briefly introduce each one and then let them fill in with any details that I might have missed. So first we have a father and daughter team, Britta and Nick Jewell. I think one is in, they're not together right now, right? They're on different opposite ends of the world, I think. But in any case, I'll introduce them. So Britta, she's a research fellow in infectious disease epidemiology at the Center for Global Disease Analysis at Imperial College in London. She holds a PhD in infectious disease epidemiology from Imperial College and a master's in the history of science, technology, and medicine from Oxford. Her father, Nick Jewell, is currently chair of biostatistics and epidemiology at the London School of Hygiene and Tropical Medicine. He's a member of the National Academy of Medicine, and he's a fellow of several different societies, so it's kind of amazing. So he's a fellow of the Royal Statistical Society, the ASA, the American Association for the Advancement of Science, the International Statistical Institute, and the Institute for Mathematical Statistics. So I'm going to quit sharing and then pass the control to them.
Great, thank you very much, Jim and Wendy. It's a great privilege here to be able to have a conversation with many colleagues around the world. We thank the National Institute for Statistical Science and the ASA for arranging this. It's important that we all get a chance to think about these issues at the current time, and we welcome the questions coming at the end. So Britta and I are going to share this presentation a little bit. I'm just going to introduce a bit, and then she'll speak, and then I'll come back for a little bit. So you've probably been following all the media attention and the scientific world. We're currently, as of last night, sitting around 3.5 million cases worldwide, with over 250,000 deaths. Of course, we're still very much in the beginning stages, a few months into this worldwide pandemic. We don't know what the attack rate will ultimately be in countries or across the world, but to just sort of scale what we've experienced in the past, the infamous 1918-1919 influenza epidemic ultimately affected approximately 1/3 of the world. These are, of course, historical figures because data was not so prolific at that point. And some were caused somewhere between 20 to 50 million, or maybe even a higher number of deaths worldwide, around 675,000 in the US. A much more recent one that we've all, many of us at least, have experienced was the H1N1 epidemic that began in Mexico many years ago. It ended up being quite infectious and infected somewhere between 10 and 20% of the world's population, but it was much less virulent than some serious flu epidemics, and only caused about 12,000 deaths ultimately in the United States. Throughout this short presentation, we'll try and tackle some of the myths that we keep hearing crop up. I guess it's a curse of our times that it's very hard to put an end to myths. But here are some of them: that the travel ban that the US implemented in late January saved many lives. It didn't really, in part because we didn't block travel from Europe, which was really the source of the New York epidemic. It did buy probably some time in the epidemic spreading throughout the United States, which of course would have been valuable if we had acted quickly, which we didn't. We didn't start testing adequately, and we still aren't testing adequately to get a sense of what's going on throughout the nation. The current myth is it's really time to open up, and there's certainly strong economic reasons to do that. But in order to do that, we're going to have to thread a needle, and we'll try and touch on that very briefly. And now I'm going to pass over to Britta to take this through the next slides.
Thanks. So this graph is really where we are in terms of daily deaths for a number of countries in the world right now. And what this really shows is that the US didn't use the additional warning time that we had over countries that experienced epidemics earlier, like South Korea, in order to have a better managed epidemic. And the US has actually done the worst so far out of all countries. Nick mentioned just now that the US wasn't testing adequately, and that is a big part of the story. The next slide. So this is the per capita testing rate for a handful of countries. And this shows that the US was really slow to get off of the ground until about April. And now the US is testing more than most countries, but it's still not as high as in Italy. So this is an encouraging sign that we've caught up somewhat, but is that really enough given what we know about the nature of the epidemic so far? Next slide. So a metric that's probably a better indication of the reach of testing is the number of tests performed per positive case. And the inverse of this would be the test positive rate, which you might have heard about. And what you really want is for that test positive rate to be relatively low, since that means that you're reaching out into the community and not finding very many new infections. So here, if you compare the countries, for the US, the number of tests performed per confirmed case is just over 5. So that equates to roughly 20% of all tests coming back positive. Whereas at the top of the graph, you can see Taiwan or New Zealand, those numbers equate to less than about 1% of tests are coming back positive. So we shouldn't really be surprised that the countries that are at the top of this graph are doing better in terms of managing their epidemics than the ones that are lower down. Next slide. So now I'm going to move on to a very brief overview of SEIR models that many of you may be familiar with. This is the most traditional type of mathematical model used for infectious diseases. And it stands for susceptible, exposed, infected, and recovered. And these types of models can be used in multiple kinds of ways. So the natural history of an infection really has to be figured out independently from studies and data, and then those parameters can be used to inform a model. And by putting that in, you can see how infections progress both through an individual or through a population over time. Sometimes models are also used to provide projections of the likely future of an epidemic, but although you might be able to estimate the scale by doing something like that, it's actually very difficult to predict the peak with precision or to make long-term predictions far into the future, particularly in the case of something like COVID-19, where people's behavior might be modified based on model projections that are feeding into government policies, and then those model projections have to then incorporate that behavior change to reflect the new reality. So it's very feedback process, and it's hard for models to predict the future perfectly. And maybe the most value from these models is being able to provide insights that might seem counterintuitive at first, or to show impacts of possible interventions that you can't collect data on in the first place. Next slide. So some of you might be quite familiar with this diagram, but just to show how these models are built up. So the point of a model like this is really to understand the speed at which people move through these compartments from susceptible to infected to recovered. And the eventual outcomes will depend a lot on the size of the compartments. So if you start with a huge pool of susceptibles, which is where the world is right now, really, that will have a lot of influence over your ultimate outcomes. This is also a very simple version of the model. So most models will tend to build in other factors like age or sex to represent the population more accurately. And really the goal here is that if you can intervene on some of these transitions between states, that means you can potentially slow down the progress of the disease or improve recovery, and that will have an effect on how the epidemic progresses in your population. And just one other type of modeling that we should note is agent-based modeling, which is what the COVID-19 model in my department at Imperial uses. So that's essentially a compartmental model like this, but it's just boiled down to an individual level, so that each person in the population is actually represented as an individual. And that allows you to incorporate a lot more heterogeneity in terms of both how people mix as well as other cofactors that might influence transitions through these compartments. Next slide. And so once you understand these transition rates, that can give you some insight into the basic reproductive number, or R0. And if you're able to reduce R0 below 1, this will end up leading to the disease dying out. So that's really where you would like to be ultimately. But if it's above 1, you will still have a continuing epidemic. And a lot of the countries that have been in lockdown so far, including the US, are potentially hovering right around an effective reproduction number of 1, which means that the situation is quite delicate in terms of removing restrictions, because even a small increase in that reproductive number can lead to the epidemic taking off again. Next slide. So we also know for a disease that has exponential growth at the beginning of an epidemic, the way that COVID-19 does, that the timing of implementing mitigation measures really matters. So this graph was done several months ago, and it's really just a thought experiment, but it's showing that if you avert one case a week earlier, that will end up averting 4 times as many infections than if over a month if you had done it a week later. So ultimately, it's just showing that intervening early in exponential growth has a much greater effect than you might intuitively expect. Sometimes people have a hard time getting their head around what exponential growth actually means and how small changes at the beginning can have a large effect down the line. Next slide. And just in terms of looking back at the US epidemic, we estimated here that about 90% of US deaths could have been averted in the first wave of the epidemic if we had started full mitigation at the beginning of March rather than in mid to late March. And this isn't really so much about the actual numbers at the end of the epidemic. So this was done based on the IHME model that Nick will touch on shortly, which was projecting about 60,000 deaths at the time, which we've unfortunately passed already. But it's more about showing the proportional reduction. So again, that intervening early can make a big difference in terms of the ultimate numbers. And of course, when averted infections here might also only be postponed infections, depending on what happens if there's a second wave and how those mitigation measures are implemented. So now if we just turn our attention back to the future, one thing that people are really focused on is the metric for assessing the cost of releasing our current mitigation measures too early. And this can't really be deaths averted anymore, since this will depend on subsequent mitigation strategies. And we know that the epidemic won't be allowed to just burn unmitigated without any measures in place. So potentially the metric here should be instead the length of time between easing these mitigation policies and the resurgence of infections. So that means that if we wait longer, we would likely have a longer period where infections stay low, in part because you can stamp out small outbreaks more easily. And a longer period of time would also give the healthcare system really a chance to catch its breath, as well as time to develop treatments and vaccines, and then also just prepare for the next stage of fighting the epidemic. So I'm going to pass it back to Nick now to talk more about some statistical issues.
Thanks, Britta. So I'm sure Mark will talk more too about these epidemiologic epidemic models. I want to touch briefly on a model that's gotten an awful lot of attention in the last month or so, and again yesterday, the so-called IHME model from the Institute for Health Metrics and Evaluation at the University of Washington. And it was very quickly picked up and actually used by the White House in the daily briefings to establish sort of the future course of the epidemic. And unfortunately, it's from a statistical point of view, it's unfortunate it's a purely statistical model. It's not based on any epidemiological understanding. It's based on modeling the death curves, the curve of cumulative deaths. And it was clear from the beginning that it was subject to a considerable number of flaws and difficulties in interpreting, taking it really seriously. And this model depended, as I said, on reported aggregate counts of deaths in various regions around the world. And the quality of that reporting is extremely poor in many countries and not really capturing the full impact of COVID-19, in part because many regions of the world to this day still only count deaths that occur in a hospital and don't count deaths at home or deaths in a nursing home. It was based at that point on Farr's law. Farr's law, named after the great English statistician William Farr from the 19th century, has made the observation that many epidemics, the number of new cases or number of new deaths tends to follow a bell-shaped or Gaussian curve. And that's extremely risky to assume that early on in an epidemic. And in fact, there's a very classic case of mistakes being made with HIV, where the use of Farr's law underpredicted the spread of the epidemic not by one order of magnitude, but by orders of magnitude of orders of magnitude. And then some other issues that are on the screen here. I did want to point out that yesterday, the IHME updated their model. The US estimate in a single day jumped from 70,000 or so to almost 140,000 in a single day. And though the media reported that, and I think IHME reported that as in part due to their understanding of easing of social mitigation, it was really largely due to the fact that they changed their model yesterday, and actually now are starting to incorporate some SEIR modeling, but I haven't had the chance to really examine the new details to the extent they're provided on their website. So not a big fan of this model. Okay, so now I just want to finish briefly with some current work that's going on that's really heavily dependent on using effective statistical ideas. This is an analysis of which I tend to rely on much more on local data using hospitalization data from Kaiser Permanente, which has as many of you know, has a fairly big market share of healthcare in the United States, particularly on the West Coast. And this is based on data coming from hospitalized cases in the Kaiser Permanente system. And I just wanted to draw your attention that by back calculating infections from the hospitalized cases, you can get a picture of the effective number. And you can see here that in Northern California and Southern California, there was a decline in the effective reproduction number before social distancing went into place because people were already responding on their own. We saw this in the HIV epidemic. We see it here now. And in Northern California, the 13th of March was the statewide. Northern California was 3 or 4 days before that, around the 9th and 10th of March. And then the effect of social distancing and reducing that effective number, reproductive number, continued after that. And this is the similar situation in the other regions. Important to point out here, and I'll come back to this, is that the reproductive number, having been reduced, has not been reduced significantly below 1 in these regions. So these regions are seeing some decline in cases, but not very far away from an exponential growth strategy with a reproductive number bigger than 1. This is related, but quite different work on using mobility data to track the effect of social distancing. And here we're looking at this, I picked out 8 states here across the country where this is based on Apple Maps mobility data that's publicly available. And you can see here the effect of the reproductive number declining over time as we went through social distancing. And these reductions are quite closely related, as this graphic shows, to the measurement of mobility picked up by Apple Maps. And there's similar analysis being done with Google Maps. And so here on the left graphic, you can see the relationship, the quite strong relationship between the current reproductive number, how many infections are happening on average per infected person, and the level of mobility, in this case, calibrated to pre-COVID-19. So the percent of a baseline date pre-COVID-19 for 4 different states. And this is really the same information on the right, but measuring how much the reproductive number is reduced by changes in mobility. And the important point here is to point out that each state has its own sort of reaction to changes in mobility because of the conditions and the way the population interacts are quite different between, let's say, Louisiana and New York. And you can see here that for New York to reduce its reproductive number, it needed a fairly sizable reduction in mobility before there was a real drop in its reproductive number, quite different from the from Washington State or from Louisiana for that matter. A big move now is to move on beyond PCR testing, and I think Dean will talk about the testing situation, but there's a great interest in not only expanding PCR testing, but expanding serological testing. And we are launching a study in Northern California to draw a sample of 5,000 individuals and collect blood and nasal secretions and saliva and test those by PCR and by antibody tests, and do this over time to get a better picture of the seroprevalence, what fraction of a population have been infected, and how that their antibody production, which is captured by a serological test, how that is changing over time, because we need to understand whether there is any evidence of a sustained immune response. The initial evidence is that it may not be for longer than several months that an antibody response is mounted, which has huge impacts for later in the year and next year, should people previously infected now become susceptible again. There was a very poor seroprevalence study already done in Santa Clara that got a lot of attention, and with a number of statistical errors. The New York surveys that you probably also saw, which showed upward of 20% of New York City already being infected by the virus, is more likely in part because it's easier to assess prevalence when you're far away from very low numbers. I do want to point out that antibody testing does not really provide at this point the possibility of creating immunity passports, of actually giving people a declaration that since they've already been infected, they will be free from reinfection and can re-enter the workplace without risk. Partly because the prevalence is so low, and a simple application of Bayes' rule here shows that with a prevalence of 1%, even if you have a fairly high and fairly realistic, these are taken from a current antibody test, fairly high sensitivity and specificity, with a prevalence of 1%, a positive test only provides a probability of 18% that you're actually antibody positive. And even if you increase the sensitivity and specificity to 99%, which is better than most antibody tests, you still would only have a 50-50 chance of being truly having antibodies if you show up with a positive test. When the prevalence increases, which of course we're trying to stop, but when it increases, this will ease somewhat. And Dean may also talk about that a little bit. Some of the current statistical issues that we've touched on and that I think are important in the future, the top ones are to do with the testing and trying to do that in a massive scale and effective and efficient way. Part of that testing is assessing quickly now the measures of immunity and to what extent immunity is actually protecting individuals and how long that immunity may last. Britta touched on that we need to do more experimentation about what the impact is of relaxing mitigation policies to ease the economic burden of shelter in place. And we are trying experiments at the University of California campuses of allowing random individuals back to working in place for essential research, and comparing infection rates, potential infection rates with those who are still required to work at home, to see what mitigation policies can be released with the least impact. That threading of the needle that we talked about. We need to develop very effective surveillance strategies as we release mitigation policies in order to detect future resurgence or outbreaks, in order to do contact tracing and try and stamp out infections. And of course, throughout all of this, as Britta mentioned, we need to buy time as much as we can for better treatments to be developed, and ultimately for the development of a vaccine. And we'll stop here and move on to Dean. And just want to point out that part of the price we're paying now is for a very large de-escalation of investment in the public health infrastructure in this country. Part of the reason South Korea did so well is that they invested so heavily in their public health infrastructure following the outbreak of the MERS coronavirus a few years ago, and they had built up their testing capacity. And I'll stop here.
Great, thank you so much. Let me introduce Dean while we're switching slides. I'm assuming you can hear me. So Dean Follman is Chief of the Biostatistics Research Branch at the National Institute of Allergy and Infectious Diseases. He has authored or co-authored more than 250 peer-reviewed research articles, and he's received numerous awards, one of which is being elected as a fellow of the American Statistical Association. He serves on numerous committees and advisory boards for the U.S. Food and Drug Administration and the National Institutes of Health. So I'll let Dean have the floor.
Thanks, Wendy, and thanks for Dr. Rosenberger for inviting me to speak here. I'm really honored to be part of this panel. I know both Nick and Mark personally. They've both actually given talks at NIAID, and on both instances I had a very nice time, so it's nice to see them again, even though it's fairly virtual. But someday we'll get together again, I'm sure. What I wanted to do was, this kind of looks like a Zoom picture, doesn't it, that we're all getting used to. I wanted to highlight some of the work that the people in my group have been doing in response to the COVID-19 epidemic. Nearly everyone is involved in this, some, majorly, some less so, but we're all sort of contributing, and I'll be highlighting different people's work in this talk. So I thought I'd start by giving a kind of generic description of what we do at NIAID to fight infectious diseases. And you can break this up into, I would say, 4 different categories. One is identification of the infectious disease. And so that leads into diagnostic testing. There's a lot of statistical issues with that. Nick touched on those too a little bit. And I'll go in a little more detail. Another thing that we want to do is describe the infectious disease, both at a population level, which leads to the kind of modeling that Nick and Mark are going to talk about, as well as what happens within an individual, sort of the natural history of the pathogen going through the host or the human. As time goes by, I'll describe that a little. And we don't just want to look and see what happens, we also want to do something about it. So that leads to what our group does a lot of, is evaluate treatments. So I'll talk about a treatment trial for COVID-19 that we've been majorly involved in. And I'll also talk about current work that's designing vaccine studies and also antibody studies to either prevent and treat COVID-19. So I'll start with diagnostics, and there are 2 major kinds of tests that we're interested in. One is called a PCR test, which identifies whether you have viral RNA in your nose. You can see a swab over here, okay. And there's a way that the viral RNA is amplified, and if it's present at some point, it'll show up in this PCR test. That measures whether you're currently infected. Another very important issue is whether you have been infected. Nick touched on this a bit as well. And the way we do this test is if you're exposed to a pathogen, generally your body will mount an immune response, and part of that immune response is to make proteins called antibodies that are exquisitely specific for the pathogen, and they'll just latch onto the pathogen. And as time goes by, those proteins or antibodies stay there, and so it's a memory of the infection that you had before. And so that's another important test that we will that we're interested in. So one issue, as you do tests, each test will take a certain amount of time. So I've got a simple example here where you have 10 samples, which would require 10 individual tests. And this would say take 10 units of work. But if the number of tests explodes, the amount of work explodes as well. So this can lead to problems with capacity, and it could overwhelm laboratories. So statistics can help out with this, actually. So there's a well-regarded and actually kind of complex and detailed work done in what's known as pooled testing. And I won't go into some of the beautiful mathematics of it here. What I'll talk about is a very simple test where you might have those same 10 samples I showed before. And what you can do is pool the first 5 and then run the test on that pool. So now you say, oh, the pool is positive. I got to figure out what's what. And so then you will test the individual samples. But the second pool here, everything's negative. So the pool turns negative and you save some work. So in this simple example, I've done 7 hours of work instead of 10. And you can kind of imagine how this would scale and how it would be dependent on the positivity rate in the pool of samples or the kinds of samples you're getting. One statistical concern with this is that, and you can imagine this I think easily, is if you have one positive test in a big pool of negatives, that positive signal might be drowned out. And so what can you do? Experimentation. And so that's what we're doing now with collaborators in India on how to pool PCR tests. We're also working with NIAID to pool serologies. And our goal is rather simple. It's just to say, can I mix 2 tests together? Can I mix 10 tests together? At what size can I still identify that one positive in the pool? And then once we know that, we'll have something sort of lab ready to deploy. So that's testing. The next thing I want to talk about is description. And the thing I want to talk about here is the incubation distribution. So SARS and COVID-19 is a new kind of disease, so we are still learning about it, including the incubation distribution. And I'd like to just run through the statistical model for a particular approach to estimate this. And I'm going to do it in a really simple setting, so it's kind of clear, I hope. In general, it's a bit more complicated. But let's suppose I have a disease that has an incubation distribution that ranges from 1 day to 4 days. And so if I knew exactly when people got infected and I knew exactly when they had symptoms, I wouldn't need statistics. I just count the 1s and the 2s and the 3s, make proportions, and that would be it. I would be done. But this is not really so easy to do, because when you're infected, the virus gets in you somehow, you might not know, and then it'll replicate in a way that your body consciously is not aware of, but your immune system is, but still you don't know. And so the time at which you were infected is fuzzy, and this leads to difficulties in estimating the incubation distribution. But Jing Shin, who's in my group, recognized that there was a kind of natural experiment going on that allowed statistical modeling to be brought to bear on it. And so I'll go over this briefly. In January, the epidemic in China was mostly in Wuhan, and on the 23rd of January, China imposed a countrywide lockdown. So that's something happening, sort of an exogenous insult to the system. How can we exploit this? So let's just think this through. Suppose there's a person, Zhang Wei, who leaves Wuhan on January 21st, and then she goes to Beijing. On January 23rd, she's stuck in her apartment. So it's like she's in a cave. She's not going to get infected when she's in this cave or her apartment. And let's suppose she tests positive on January 30th. Well, then we can conclude she must have got it in Wuhan. Yeah, so it's probably at least 9 days, but can we do better than that in estimating the incubation distribution? So actually you can. And what I'd like to show on this slide is basically to illustrate the method here. Remember, I've got an incubation period of at most 4 days. And if I have a person who shows up 4 days after the lockdown, how could they have symptoms 4 days after the lockdown? Well, the only way they can have it is they were infected on day 0, and then they were one of those people who are destined to have a 4-day period of incubation. So I can write this out.
Having trouble hearing you.
Can people hear me? Well, let me just continue.
I can hear you, Dean, and I can see your slides, but not everyone can. So
I'm sorry.
But I think you need to continue. We're recording it.
Okay, I'm sorry about that. Anyway, so you can decompose this and write the probability of symptoms on day 4 as under a steady state assumption, 1/4 times the probability that a person has that number 4. And you can decompose all these different proportions, people who show up with symptoms on day 4, 3, 2, 1, etc. You get 4 equations, 4 unknowns, and you can solve this. So this is what Jing Qin did to estimate the incubation distribution. The next thing I want to talk about is the treatment study. So early on, we were involved in designing a treatment study, and this was designed by Lori Dodd and Mike Proscian, and then Tyler Bonnet on the far right worked with them through the analysis of the study. This was a classical trial in the sense that it was double-blind, randomized trial of the drug remdesivir versus placebo in patients with severe COVID-19 disease. And we didn't know a lot about COVID-19 when we were designing this in February. And so we repurposed an ordinal scale that had been developed for influenza. And it has 8 different categories that we applied to this study. And as time went by, we thought maybe there are some fragilities with this particular ordinal scale. For example, being on invasive ventilation might be dependent on availability, and being released from the hospital might depend on capacity in the hospital or not. And so instead of being a direct measure of how of a patient's health or feels, functions, and survives, it's also dependent to some extent on the logistics of the situation. And probably more importantly, we were concerned that day 14 might not be the optimal day to identify treatment effects. You know, we're thinking originally about the flu, but as time went by, we got more information from China, and there were published clinical trials reporting the course of the disease better. And so we wondered about whether we should respond to this and think about what to do. So we did simulations to try and evaluate what we thought would happen now that we knew more about COVID-19. And one of the simulations that we worked on, this is kind of difficult because I hadn't really worked with the proportional odds model before, and now I've got to do a longitudinal proportional odds model. And so we sort of put together this particular approach, which would take a random curve for each person. So for each person, I draw a random intercept and slope times the log of the days since randomization. And what I've graphed here is sort of 100 random trajectories from this kind of random effects curve fitting model, or curve model. I imagine this as sort of everyone picks a slide and then they slide down either into recovery, clicking off when their value changes from a real number to an integer, and that's the ordinal category. Some percentage of these are sort of destined to pass away, and so there's certain curves that go up. So this was the curve fitting, this is the curve simulation that we worked on. And we did this to try and tweak the parameters of the simulation, try and understand better the performance of different statistical tests that we might use. And so on the bottom, there's a slew of tests here, actually. And I would say, based on this and other simulations and talking with other researchers who were involved in COVID-19 trials, we settled on a different kind of endpoint, which was the time to recovery. In this instance, it would be time until you achieved an ordinal score of 0. And you can see in this simulation, it's got decent power. It's competitive with many of the other tests. And so that was good. But we also are mindful of, in an endpoint for a clinical trial, we want to see something that means something to people. So we would say check on recovery, and also something that people can understand and explain as well. These are all important considerations when you decide how you're going to determine whether a treatment works or not. So we ended up switching the endpoint to time to recovery. So there's a little detail here is how do you treat deaths? Well, the way you treat deaths is to recognize that people who die can never recover, so we sent their times to infinity. And once you do that, we use a rather standard method to assess whether the time to recovery is proved over the period of follow-up. There's actually, this corresponds to the way of estimating the cumulative incidence of recoveries. And I've got a picture over here. This is not the remdesivir study, that's still under peer review. So I just wanted to show in a trial that was done in China by Cao what this cumulative incidence looks like for time to recovery. So we designed the study to achieve 400 recoveries, and it was accruing extremely rapidly. Sometimes people give the analogy of drinking from a fire hose, and I think that's kind of apt here. And we had to think quickly about what to do and think about that endpoint and so on, using the Chinese data and published literature. It turned out that the first interim look, we had more than 400 recoveries, and so it was kind of the final look. And we were able to show that there was a 31% faster rate of recovery on remdesivir compared to placebo, which was significant. This was the primary endpoint. We also showed a benefit, not statistically significant, but trending towards a benefit on mortality. And here's the median time. So this was announced on April 29th, less than a week ago, by Dr. Fauci, the head of our institute, at a White House meeting. And then on Friday, just last Friday, May 1st, the Food and Drug Administration gave an emergency use authorization for remdesivir. So that's being deployed now and giving out through the country. And so this ACT infrastructure is now, we're going to go on to ACT 2, where we have another treatment modality that's been selected, and I think the protocol will be published soon, and will be starting to randomize later this week or early next week. So I want to finish up or go next to prevention after treatment. Maybe prevention should come first, but anyway, I'll talk about it now. So one of the issues that was being discussed probably a week ago, I think it's settled now, but was how do you measure success with a vaccine? So we were talking about two different possible endpoints. One is just whether you've been infected, which would be denoted by being PCR positive. Remember, that's where you stick that swab up a person's nose and see if there's viral RNA there. And if it is, you're positive. But it's more traditional in vaccine trials to say, we want to prevent something that's consequential to the patient. And so another endpoint is to look at whether you are PCR positive for the virus. So you got the germ, you got the virus, but you also have symptomatic disease, so it's affecting you. And there are a couple issues in selecting this endpoint, which will be more sensitive rather to vaccine effects, because we want to pick an endpoint that is sensitive to vaccine effects. And we also want it to be meaningful in whether it would help patient health or not. And so I made up some data here to sort of illustrate what would happen if the major effect of the vaccine is not to lessen disease severity. So the infections still happen, but a lot of them are just sort of meaningless. They don't have any clinical consequence to you. So here's an example where there's sort of a vaccine lift, where you're lifted from these worse categories into these better categories. And in this example, it shows pretty clearly that what you should choose is the disease endpoint. If the vaccine has little effect on infection, but its major effect is on disease, and that's truly what we care about in a preventative vaccine, we should stick with disease. So we're going to use time to disease or disease proportion as an endpoint at a fixed time. Another analysis that we're interested in is to try and to incorporate the severity of the disease in a particular way. And there's a couple of ways we can do this. It's easiest to explain the first one, or the non-traditional one, in the following ways, where we'll do a traditional time to event analysis, but then if you have mild disease, we score it once. If you're hospitalized, you score it twice. And if you're dead, we score it 3. So this reflects the idea that not all symptomatic disease is the same. Worse outcomes are counted worse. And we've done some simulations here to look at the statistical power of different methods of analysis, where we do a simple Wilcoxon test comparing those scores 0, 1, 2, 3. We do a traditional time to event model. And then we do sort of a traditional time to event model, but where we do this weighting. And that seems to have the most power. And so it has a certain amount of appeal to provide a kind of integrated analysis. And the final thing I want to talk about is another prevention modality that relies on antibodies. So if you're infected with COVID-19 and recover, you'll have these antibodies, these Y-shaped proteins that are exquisitely specific for SARS coronavirus. And if I take the antibodies from someone who's recovered, or I figure out how to mass produce those and make clones of that antibody, I have a potent treatment for either prevention or to treat someone who's sick. So and they work immediately, unlike a vaccine where you vaccinate someone and you have to wait weeks and maybe many weeks to have a response to get those antibodies up and going. When you have monoclonal antibodies, they work immediately. So the idea for this kind of prevention study would be to identify someone who's sick with COVID-19 and give them antibodies. And those antibodies can help that person be treated. And then the rest of the family give antibodies as well. And that can help them from being accumulating or acquiring the disease. So this is sort of a trial where we would randomize the entire family to either these antibodies or placebo. And it's kind of a twofer in the sense that it's a treatment trial for the index case and it's a prevention trial for the other family members. And there's a really interesting and involved statistical and modeling literature on these so-called indirect effects that we might benefit from using this particular design. And I'll just run it through it quickly and conceptually. So let's suppose I have a placebo family where the index case ends up infecting a sibling who infects someone else. And now let's imagine counterfactually that this identical family was gotten the vaccine, which works in half the people and doesn't work in half the people. But the index case tries to infect this person who's been protected by the vaccine, but it doesn't happen because he's protected. And thus, indirectly, this person is protected even though the vaccine didn't work in them. So anyway, if you imagine a ton of families like this, it's easy to show that if you randomize families under this ring design or a total control design, you protect about 3/4 of the family. If you randomize individuals, you protect about 50%. I think I'm out of time, but I just want to say, for me, it's a privilege to work with these people at NIAID at the Biostatistics Research Branch. We're a tight group, and I'm really proud of everyone there. And I'd also like to thank my other collaborators who've worked on this. Thanks.
Great, thank you, Dean. Okay, perfect. So next, Mark, if you could share your screen and I'll introduce you. So Mark is a professor of epidemiology at Harvard University. He's the director of the Center for Communicable Disease Dynamics, which is a center of excellence funded by the MIDAS program of the National Institutes of Health. He's also the associate director of the Interdisciplinary Concentration in Infectious Disease Epidemiology. So you have the floor, Mark.
Okay, thank you very much, Dr. Martinez, and and to the other hosts for the opportunity to be here. I want to discuss mostly some work that was done led by Stephen Kissler and Christine Tedianto with Jonathan Grad on seasonality and modeling of COVID-19. And then at the end, I'll describe briefly some other work that I think has some interesting connections to statistics. So I want to begin, and thanks to the other speakers for providing a lot of background, which makes my task easier. So I'm going to jump right in. As you may be aware, the SARS-CoV-2 is part of a larger group called the beta coronaviruses. And when this first started, we thought, well, everyone's going to want to know about seasonality and we won't have good data. So what can we learn from existing data on other beta coronaviruses that may inform our estimates for this one? And so we quickly started working with data that the CDC had been gathering over several years. And as you know, if you get a cold, which is the typical manifestation of beta coronaviruses, you don't go to the doctor and get a diagnosis and have them tell you, oh, this is virus HKU1 typically. You just sort of tough it out and hope you get better, and you do. And so one of the challenges with cold viruses and flu viruses and other things that often don't get diagnosed is that we don't know how many cases they cause. And so there's a whole discussion of how best to try to quantify coronavirus incidence. And the choice that we made, and all of this is from a paper that was published in Science about a month ago, the choice that we made on in this case was to use a product of the percent of all tested specimens in a week that were positive. So it turns out some people do get tested when they have colds, times the proportion of visits that are positive for influenza-like illness in a surveillance system. So there are many things you could say about this. It is not the perfect way of measuring incidence, but it is not a bad way. And it turns out that all the other pretty okay ways that we could think of give approximately the same answer. So this is what we did. And when you do that, and I should say these two curves are two of the two different major beta coronaviruses, HKU1 and OC43, which are labeled down here. It's just names of two different viruses. What you can do then is using work that was done during SARS-1 by Jaco Wallinga and Peter Tunis, you can make an estimate of the weekly reproduction number. So you heard about the basic reproduction number. This is the effective reproduction number that's going up and down over the course of the year for really two reasons. The first reason being that that weather and other factors that we don't know precisely, but calendar time in some way, month of the year or week of the year has an impact on the transmission of this virus. And you can see that it's typically most cases right around the first of the year, a little before and a little after. And the other is the accumulation of immunity as people get infected and recover in the population. And so using some further developments that same group at the RIVM in the Netherlands had pioneered, we fit this log linear regression to the reproduction number. So what this approach says is that the reproduction number in some week is equal to some baseline reproduction number, and it's all on a log scale, so multiplied by a term for the cumulative incidence of infections with that virus, multiplied by the cumulative incidence, a term for the cumulative incidence from the other virus, and then a spline fit, which is this yellow thing that is a seasonal variability. And you can see if you look with the eye of faith, you could call this something like a sinusoid. It peaks around the November or so, and the trough is around the spring and summer. And we assume that that's the same each year, and then try to partition the estimates of changing reproduction number between accumulation of immunity to each of these two viruses and the seasonal forcing. At the same time, along with that statistical approach, we took a transmission dynamic modeling approach. So you heard about SEIR models, and this has a sort of Tibetan look to it, but it's not. It's just an SEIR model with two strains. So you're susceptible to both strains. You get exposed to one strain going down to the right or exposed to the other going down to the left, and you eventually could recover from both. And using this two-strain version of an SEIR model and fitting the degree of seasonal variation in transmissibility, we get an estimate, or we can fit these trends. This is just a redrawn version of the actual number of cases per week, or the incidence proxy per week in the solid lines and the simulated in the dashed lines. And you can see that you get this alternation between the two strains because each strain builds up immunity to itself and to a lesser degree to the other strain. And then the next winter, you get the other strain. And with fitted parameters of about a 21% reduction in transmissibility from trough to peak, so this is 21% below this, you get a fit that is fairly consistent with what we found with the unconstrained non-parametric approach, especially during the periods of high numbers of cases where the data are strong, and less so during the periods where the data are sparse. And so we have sort of two separate lines of evidence. It's the same data, but two different analysis approaches that both give us around a 20% reduction in the amount of transmission by season, due to seasonal forcing. The rest of that decline after the winter peak is due to the depletion of the susceptibles. So this would not be enough if this were similar for SARS-CoV-2, given the estimates of the reproduction number between 2 and 3 by most groups, and actually, in my view, a fairly credible estimate that it may be 4 or 5 by another group at Los Alamos. I'm curious what others think about that. I think it makes some sense. In either case, you would not expect that a 20% decline to be enough to bring this under control. There are many limitations to this approach, and I would also refer you to excellent work by Tama Carlton and Mauricio Santillana, separate efforts that focus on the actual seasonality of SARS-CoV-2, which of course has more limited data. So then from there, we decided to try to project what would happen with and without intervention. And so when you run that three-strain version of that SEIR model, it turns out that you have many different scenarios for what could happen, including, depending on the amount of immunity and cross-immunity, anything running from annual outbreaks where all three viruses are present, all the way up to elimination if there's permanent immunity or to SARS-CoV-2. And this is all in the absence of control. So then we wanted to look at control, and we wanted to focus on SARS-CoV-2. So we simplified the model back down to a model actually that's essentially the same, the non-agent-based compartmental simplified model, similar to what the Imperial group had used, because there was nothing we could think of to improve on it, with the same, with similar kinds of delays, where individuals are destined either to become mild illnesses in almost 96% of the cases, or to be hospitalized or go to critical care. And our questions were two. One is, what would social distancing look like? What would impacts of social distancing look like? Control measures. And the second was, what would the impact of seasonality on that be? And what we found was that one-shot social distancing, which was sort of the, I think what was in many people's minds initially, and is perhaps in some other people's minds still, doesn't really work to control the epidemic. It delays the epidemic, it delays the peak. If it's very effective and long enough, so the green is the most effective social distancing, reducing the reproduction number by 60%, it delays the peak and delays it into the higher transmission season, which that thereby makes it even larger than it would have been. On the other hand, a sustained and mildly effective social distancing approach allows the epidemic to come into two peaks and pushes the second peak actually past the highest point of transmissibility. So you actually get a much better outcome. That dividing an epidemic into two pieces reduces what's known as the overshoot, which was written about in the New York Times last week by Carl Bergstrom and Natalie Dean. And so it makes a better outcome. And then last, we wanted to look at a notion of intermittent social distancing, where a period of social distancing is followed by a period of releasing it. And here the goal was to try to protect the intensive care capacity. So the the parameters here were set by going on social distancing when the caseload was enough so that the red, which is the intensive care burden, would approach the capacity shown by the black line, and off when it's low enough so that you are allowed a period of growth. And what we find is that this leads to quite a long sustained period of social distancing during which at the estimates of herd immunity that were current at the time, it really grows very slowly. And it takes a lot of these episodes of on and off to try to get anywhere close to even 50% herd immunity. But seasonality helps because it means that you have this longer period in the summer where you can be off of social distancing for a longer period. And then the last finding from this was that the presence of either greater intensive care capacity or of equivalently of a treatment that cuts the demand for intensive care by saving people from long-term or from severe cases allows both longer off periods and faster accumulation of herd immunity. So our conclusions were that one-time distancing is not enough, and that the impact of distancing is not monotonic in either duration or intensity. And that if our estimates are correct about the proportion of cases that are mild versus severe and critical, then several years of distancing might be required to get to herd immunity without overwhelming the ICU. This is a very 100,000-foot view, of course. This is looking at the whole country without the subtleties of local conditions, and much more is to be said. I think this was meant as a first look. And then the seasonality has interesting interactions between with one-time or multiple social distancing. I want to close by just drawing some connections, because my training is not in statistics. It's an honor to be among this august group, but I think there are really interesting interactions between the kind of modeling that I just described and more statistical approaches. And this is a paper that came out of a workshop that we held with Beth Halloran's leadership a few years ago to look at these. So I want to just have three brief vignettes. One on work that's not yet even on medRxiv. It's under review there, or it's in the process at medRxiv. And it's to look at how the issue that was raised by both of the previous speakers about seroprotection. If you wanted to estimate the protective effect of prior infection on future risk of infection, how would you do that? And this is, in thinking in causal terms, this is a really challenging problem, because we're interested in the relationship between seropositivity and infection. But of course, the cause of seropositivity is prior infection if you don't have a vaccine. And so it's always a problem to have confounding in observational studies, but when essentially the exposure and the outcome are the same thing at different times, then all sorts of things are common causes of the exposure and the outcome. So there are a lot of those you could think of, but one that's maybe less obvious is the issue of geographic structure and epidemic dynamics. So, so this is a simulation of an epidemic in 1 or 10 communities. And I won't go into the details, but just to show you what we were thinking about, we were asking, if you did a study where you compared those who were seropositive against those who were seronegative, i.e. those who had previously been infected against those who hadn't, would you correctly recover the null result if in fact there was no seroprotection? And if you have a single community and everybody enrolls on the same day, then the answer is yes, you get the right answer. It's a pretty straightforward study. But because of epidemic dynamics, in fact, if you, for example, have one community but different days of enrollment, then you have this phenomenon that you have people enrolled on early days are more likely to be seronegative because they haven't been infected. People enrolled on late days are more likely to be seropositive because more of them have been infected. And the people enrolled on late days have a higher hazard of infection, average hazard of infection during their follow-up. And so you get the wrong answer, you get a positively biased hazard ratio, which can be fixed by matching or stratifying. And we went through a whole bunch of other scenarios, which are in the paper and you're welcome to read, but I will skip. Next, I want to just mention briefly some work that's not by me, but by colleagues at the Center for Communicable Disease Dynamics. We heard about the problems with some of the serosurveys that have been done, and these colleagues and alumni have built a nice calculator for trying to figure out sample size and incorporating the uncertainty about test characteristics. And I refer you to those if that's something of interest. And then last, I just want to make a little plug for something I mentioned to Dean when we were discussing vaccine trials. When you have a vaccine trial against a pathogen which is often subclinical, where you sometimes don't observe the infection, it turns out that simple Cox analyses will get the wrong answer for vaccine efficacy. They will underestimate vaccine efficacy, biased toward the null, because there are unobserved infections, especially in the control group, thereby depleting person time in an unobserved way. And we worked through this in a paper last year led by Rebecca Kahn, and found some simple ways to correct it, mainly by using serology at the end of the study, even of a sample. So I mentioned this last one and all these vignettes just to say I think there are some really interesting connections between the kind of dynamic modeling that I usually do and the kind of statistical approaches that many other people do and that I've been trying to learn in order to try to ride that synergy. And so these are two papers. We also just wrote a short comment in Nature Medicine a few weeks ago that describes this issue in more detail. So I'll stop there and thank you for your attention.
Thank you very much, Mark. So I think we have time for questions. Jim, how do you want to do this? We'll tag team. I don't hear Jim. Did he leave?
Sorry.
Okay.
I see we have about 20 questions in the box. So why don't let's tag team.
Okay. All right. So I'm going to start. I mean, we have 25 questions or so I'm sure we won't get to all of them. But I'll just start at the top, and then maybe we could skip around so that all the speakers will have a question. But this is from Nick and Britta's talk. You mentioned a ban related to China, or it was a travel ban. And is this a ban China implemented on travel, or that the U.S. implemented on travel to China?
My comments there, Wendy, were in reference to the U.S. ban for travel from China, directly from China into the United States at the end of January of this year. Not referring to travel bans within China or out of China.
Great, thank you. Okay, Jim, I'll let you ask one.
Okay, let me jump. If we only use symptomatic people to estimate R0, the generation time, are we not assuming that asymptomatic people have similar times of infectiousness as symptomatic? And is that plausible? And is that risky, since we know that it is asymptomatically transmitted?
I could take that if you want. So if we do make that assumption, mainly because we don't have a good way to identify the asymptomatics early on, typically. There's a lot of work on better ways to estimate the reproduction number. If that is true, and if the asymptomatics are a constant proportion of all the total cases, then you don't get it wrong because you're just observing a constant fraction of an exponentially growing process and it doesn't matter. But if the generation time is different, there are a million ways to get it wrong by violating any of these assumptions. And So it's important to try lots of different approaches and acknowledge those uncertainties.
It might be worth pointing out that the use of the term asymptomatic can be a little confusing to some people, because many asymptomatic people may simply be pre-symptomatic, and they may ultimately go on to show symptoms. And so you have to be careful in distinguishing those. It is plausible amongst children there are genuinely asymptomatic children who never show symptoms, and their role in their ability to transmit is certainly key to understanding whether certain mitigation measures are useful or not.
I'll ask a short one here. How did you know the true prevalence of the disease? I'm not sure which talk that was, but maybe the second talk? So maybe Dean?
Oh, yeah. So I think this probably relates to the idea of pool testing, and it's clear if like 90% of them are going to read positive, it's dumb to pool. And so you kind of need to know what fraction are going to read positive to pick a good pooling size. And you learn that just by, you know, doing a week's worth of work, basically. And then you'll know, gee, it's about 2% now or 20%. And then for the next week, you could adjust accordingly.
Let me ask one from an anonymous attendee. In the context of reopening, how about recommending to let the older people work from home for a longer period of time and less vulnerable part of the population begin opening? Who wants to tackle that?
Well, I think it sounds logical. I don't know. Nick?
It's logical. It's just very difficult to easily separate elderly people from young people in terms of eliminating mixing possibilities. So the problem I saw from the beginning in trying to do segregated social distancing and have elderly people not social distance and young people all get infected so they would develop herd immunity, is that it really is not feasible to separate out elderly. My wife and I happen to be living on our own, so that's possible for us, but for many people around the country, they have very different living conditions and generations mix together within households. And the concept that you can completely isolate the vulnerable is very problematic, it seems to me. I don't see that kind of ability, at least in the United States.
Yeah, I would add three other things. I agree with that. One thing is, someone on the chat said it sounds like discrimination, and I think there is an aspect of that there are some social reasons why you might want not to do that, or other reasons. A second thing is, I think this is the sort of common small risk factors versus rare large risk factors problem that of course it is much worse to be an elderly person with comorbidities in terms of death, but there are a lot more young healthy people, and it's not costless to let it run through that population. And then the third thing I would say is that we've sort of done that experiment, and you could interpret this two ways. A huge proportion of the deaths that are known so far are in nursing homes, and that's while we're trying to social distance everyone. So I think it proves two things. One is, or it shows that removing people from that isolating the elderly is not possible, even when we're trying to make everyone social distance. And then I guess the question is, how do you interpret that? Do you say, well, if we can't protect them anyway, why not just let the epidemic run? But I think it would get much worse. But I think we've shown how well we can isolate the elderly when even with everyone isolated, we have quite a number of outbreaks in nursing homes.
I guess I wasn't thinking of this isolation or special treatment for the elderly would be sort of by government edict, but more like understanding and maybe allowing more telework for certain people, or if the elderly or seniors choose to do more social distancing, sort of encourage that, or being understanding of it.
Can't argue with that.
Right, thank you. So next question. There is some retrospective analysis of patients presenting in December 2019 and early 2020 who have symptoms now recognized as likely COVID. How much impact would changing knowledge about early cases have on the models going forward?
Mark, that sounds like something you might have an opinion of.
I was going to let Britta take it. I mean, yeah, I think at this point, the past, by which I mean ancient history like December, is not hugely relevant to the future course. We've been uncertain about the number of true cases and the starting point and all of that, and we're still uncertain. And whether the first case was in December or January is, I think, kind of beside the point when we have 3% seroprevalence in one place and 30% in another. I think if we anchor to the present, it doesn't really matter that much about the past. These are Markovian models, essentially.
I think the early interest in that question was the idea or the concept that there may have been much broader exposure to the virus and therefore much bigger immunity available. I don't think that's really been borne out, as Mark has said, by seroprevalence studies lay that to rest, because we can actually get real-time information on infections. There were a lot of upper respiratory infections moving around the world in December. And I can't tell you how many stories I've heard of people who believed that they were infected with COVID-19 in December, including myself, because I suffered from a very severe upper respiratory infection in December. But there were other things going around the world, and absent seroprevalence studies, it's just a lot of speculation. And so I sort of agree with Mark that now that we have the ability to do this effectively in populations, that's the information we need, not just speculation about what happened in December.
I was also just going to add that there's a lot of stochasticity at the beginning of an epidemic. So just because there was an infection, it doesn't necessarily mean that it translated into, some kind of asymptomatic epidemic in the background. There were probably lots of introductions in many places that didn't really turn into very much.
Let me try to combine two questions. One is, how accurate are the PCR tests, and do false negatives undermine the group testing strategy? That's sort of aimed at Dean, but also there are a lot of new tests that seem to be coming on the market, advertised by various companies, and without knowing the specificity and the sensitivity, how dangerous is that for public policy to base the results on that?
Yeah, so I'll take a crack at that. I think for the false negative rates with group testing or pooling, I didn't get into this for time's sake, but I would do experiments that would pool and compare that to individuals, and then rerun individual samples to see how similar they were. And so if sort of the overall false negative rate was similar for pooling versus individual, then I'll say pooling's okay. And I'm kind of agnostic about this issue of false positive, because whether I pool or not, I'm kind of getting the same answer from this imperfect test. And what more could I get out of pooling? But then the larger question is, has to do with the values of sensitivity and specificity. I don't have much to say about that. I'm not sort of on top of those values for all the tests. I think the studies haven't really been done for serology so well, and that's an ongoing thing. Maybe the other speakers could talk more about the accuracy of the different tests.
I would just add, Dean, to that, that in addition to doing an assessment whether pooling changes the sensitivity and specificity, if you assume that it doesn't, or you have evidence that it doesn't, then it's easy to adjust for misclassification in pool testing. And in fact, with low prevalence, you can actually get more precise results from pool testing than you can from individual testing, because pooling sort of lowers the misclassification overall in a sense. So it's not as big a, it can actually be your friend a little bit if you have very low prevalence. That goes away, that advantage disappears quickly if prevalence becomes much higher. But so does the value of pool testing, as you pointed out, diminish if you get very high rates of positivity.
On the PCR tests, I think my understanding is that what they call the analytical sensitivity is extremely high, meaning if there's any virus there, it will be detected. But whether there's virus there depends on who's doing the swabbing, how well they do it, what site they happen to brush as they're swabbing, and that I think people are estimating is in the tens of percents not sensitive, because, and I think that may explain a lot of the so-called reinfection events that happened in Korea and China that were just people who had multiple false negatives that weren't the tests problem, they were the swabs problem.
And there is a problem with the PCR test not picking up pre-symptomatic infections very accurately early on. So you sort of, I think you need to be somewhat symptomatic for PCR tests to be very effective. So there's a window there of time during a course of infection where you can detect it. But the trouble with massive PCR testing in a population is that with ongoing community transmission, you can test someone today and they'd be infected tomorrow. And it doesn't, you sort of have to keep testing if you really want to detect infections.
Thank you. Jim, do we have time for one more?
I'll give you one more, but a short one. Yep.
Okay. Maybe this won't be too short, but what will be the best strategies to reduce the number of new cases in a resource-poor setting? What are the essential factors needed to adjust to estimate the probability of the recurrent events? So that's a 2-1, but sorry.
Well, I think Britta could address that because she's been working with the impact of COVID-19 in low-income countries.
I wouldn't say I have a good answer for how to mitigate COVID-19, but the work that I've been doing with colleagues at Imperial has been looking at the impact on other diseases like HIV, malaria, and TB, if such mitigation measures are put in place and then affect the pipeline for those diseases. So I think the one thing I would say on that is that low income countries, particularly if they have a high burden of other diseases, can't really afford to take their eye off the ball in other areas as well. But I don't know if others have mitigation strategies that would be specific to low income countries for COVID.
Well, I think we're out of time. Thank you, Wendy, for being our co-sponsor for this event. And thanks to you all, the speakers, for wonderful input, and for the 600 plus attendees who've joined in for most of this presentation. In about 10 days on May 14, we have another event. So look at the NISS website. And as Wendy already said, there's ongoing activity on the ASA website. Hopefully we'll solve this eventually and all get back together. Thank you again.
Thank you, Jim.
Yeah,
Thanks,
thank
Wendy.
You.
Thanks all. Nice seeing you.
Take care.